Welcome to the session of online class. Today's topic of discussion will be about the temporomandibular joint. Okay, and today I'll enlighten you about the temporomandibular joint and its clinical implications. The first and foremost, before starting with this topic about the temporomandibular joint, I'll refresh you the basic anatomy of temporomandibular joint. The basic anatomy of temporomandibular joint is formed between the condylar process of the mandible. Okay, that is the prime part of your TMJ. Next is the mandibular fossa. When you see the picture over here, you can see the mandibular fossa. And the other adjoining structures, which is important, is the articular eminence. When you see anterior to the mandibular fossa, you'll see the articular eminence. And the other structure which plays a vital role is your, like all of the joints, the intra-articular disc. Okay, the other structure is the intra-articular disc. Okay, now before going into those structures, a brief note about the temporomandibular joint. As you all know, been going through in your first year anatomy. Okay, just refresh your first year anatomy at the neck, the temporomandibular joint. It is elymoid, arthroidal, synovial, compound joint. Okay, when you mention or say about a temporomandibular joint, the lower joint is purely an hinge joint. The upper part is a movable sliding joint. So TMJ is a compound joint, as I said earlier, of three bones: the condylar process of the mandible, the mandibular fossa of the temporal bone, and the articular eminence that is present anterior to the fossa. These three bones form the prime structure of your temporomandibular joint. And the articular disc, as I told earlier, the articular disc is the fibrous part that is there in the joint. Okay, now coming to the articular disc. Okay, it is concave or convex superiorly and concave inferiorly. Composed of is nothing but a dense fibrous connective tissue and doesn't have any blood vessels or nerve fibers. This is about the articular disc. Now, when you see about these structures, okay, the other important thing is the muscle attachment to your TMJ. The muscle attachment that is generally seen is your superior, that is most commonly is the main muscle is your lateral pterygoid. Lateral pterygoid muscle is attached to the neck of your condyle. Okay, the superior and the inferior bellies of the lateral pterygoid muscle. That is the main muscular attachment of your temporomandibular joint. Okay. Then before going into those structures, you should know about the functions of the temporomandibular joint. What all function that is possible with the temporomandibular joint. These muscle structures plays a major role in the mouth opening, jaw movements, lateral movements, all those things. That is through your muscular action. Okay, your mandible is positioned, or the main aspect of your lateral pterygoid muscle is these muscles are called as elevators. That is opening of your mouth. See, suppose, and now you people are there in the clinical postings. you will be the first to see the patients. In general examination of all the patients, the first thing that the clinician sees is you'll ask the patient to open his mouth. And that point itself, you can note whether any abnormality is there in the temporomandibular joint or not. If suppose any issue is there in the joint, naturally patient can't open his mouth. There can be inadequate mouth opening, or in some cases, some patients will have difficulty in mouth opening, or restricted mouth opening, or there will be no mouth opening at all. Okay, that is called as, the terminology is trismus. Trismus is nothing but difficulty in mouth opening or unable to open his mouth adequately. So, for suppose in a OPD, when you see a patient, the main thing you should rule out is whether you have to see whether it's having adequate mouth opening. See, there are various reasons for trismus. Okay, it can be a simple muscle spasm, or any joint inflammation, or patients having any lesion in the oral cavity, intraorally. So, severe pain will be there, he'll have difficulty in mouth opening, or patients having any cancerous lesion, or most commonly after any RTA or after any trauma to the facial structures. Then, if any fracture is there in the bones, the maxilla or mandible, then naturally he'll have difficulty in his mouth opening. So, any patient, clinically when you assess, you see for the clinical sign and symptoms. Okay, that is the reason behind this topic. That is more useful for the general practitioners. Okay, you will be the first person to evaluate the patient. Then you should be in a position to communicate with the proper consultant. So you should assess where the problem is. The main trump card of your practice is your diagnosis. A good clinician should not miss any symptoms or sign. Should not miss any sign when he is evaluating the patient. So see, for suppose, henceforth, what you are supposed to do is you check for the mouth opening or any deviation is there. Not when any deviation is there in the path of closure. Okay, any facial asymmetry is there. Then you should think about the temporomandibular joint. This plays a vital role. Okay, if suppose all these conditions, clinical conditions, what I am explaining to you. Okay, if any fracture is there in the temporomandibular joint, or a simple muscle spasm is there in the lateral pterygoid, or suppose you will see about something called as locked jaw, where there will be attrition of your articular immense. When I told about the structure of the temporomandibular joint, you should care about your condyle, how it is. Then the mandibular fossa. The anteriorly you see the articular eminence. If suppose a patient is having any attrition of the articular eminence is there, during jaw movements, what will really happen is the condyle of the mandible will slide more forward. Then it will be held in that position only. Patient can't close his mouth. That is called as a locked jaw. That is primarily a pathology that is lying underneath the temporomandibular joint. You are supposed to evaluate, diagnose the condition properly. Then you will be a good clinician. So now coming again to this topic of the structures, the muscular attachments of the, okay, then the other thing, okay, first we saw about the articular disc, then we bothered about the muscle attachments. Then the other thing is the capsule. This is also an important structure. Okay, it is fibrous membrane that surrounds the joint, and it incorporates the articular eminence. As I told you previously, this capsule, okay, it surrounds, it engulfs the entire temporamandibular joint, and it is attached to the articular eminence and to the neck of the condyle. There is where the capsule is present. Now, the other thing, okay, when we are speaking about the functions of the temporomandibular joint, then you should know some basic things about the adjoining structures, your muscle attachments. As I told you, the lateral pterygoid is attached to the neck of the condyle, the superior and the inferior belly of your lateral pterygoid muscle. Now, a brief note about the muscles of mastication. Okay, the prime muscles of mastication are your temporalis, your masseter, your maxilla, and your mandible. Okay. Okay. Then, when we are speaking about the problems that arises in the temporomandibular joint, most commonest thing is, as with all other joints in the human body, okay, this temporomandibular joints, the more commonly seen problem is your displacement, or the other thing is dislocation with reduction, and the third one is that is not of that much commonly seen, your dislocation without reduction. The other is called as internal derangements of your temporomandibular joint. Okay, most commonly seen is your disc displacement. Okay, okay. Then the most commonest types is your deviation in the path of closure. Then there will be spontaneous dislocation. That means the jaw movements won't be in proper term. The normal average mouth opening for all individual is the range of 40 mm, or otherwise, clinically speaking, 3 fingers. Okay, that is the normal mouth opening. Okay, if there is deviation in the path of closure, or if there is recurrent dislocation of your joint, then you can term it as internal derangement. Now, coming to the signs of any TMJ disorder, as I told you earlier, the most commonly seen when you examine a patient, as I told you, you check for the mouth opening. Then the other thing you can look for is your joint sounds. Suppose you hear an abnormal sound. Abnormal sound can be auscultated with your stethoscope. If you want to hear it more clearly, then keep your stethoscope, auscultation. Okay. Most common is your crepitus, or clicking is seen. See, then you ask the patient to open his mouth. That time, you will hear one click. That is called as an opening click. And when he is closing the mouth, again you will hear an abnormal sound. That is your closing click. If suppose any TMJ disorder is there, you can very readily understand with this clinical sign. That is a very important sign. You people should not miss when you examine any TMJ. Then the most one is your disc derangement. That can be a inflammatory disorders of the TMJ. Okay. Inflammation of your TMJ. It can be, one is your synovitis. Then inflammation is seen in the capsule of your temporomandibular joint. That is called as capsulitis. And any problem with the disc is called as retrodiscal discitis. And as with all other joints, there can be arthritis of your temporomandibular joint. The associated structures, okay, that will mimic as if there are pain in the temporomandibular joint. That means any pain, inflammation is there in the temporomandibular joint, you can evaluate with these 4 conditions. Otherwise, you have to check the associated structures that is seen around that, those things. That is your tendon, temporal tendonitis, or your stylomandibular ligament inflammation, or osteoarthritis, most common arthritic disease that affects the TMJ. Okay, and otherwise called as a degenerative joint disease. Okay, if suppose now thing is that you should more commonly see is your to evaluate whether any pain, tenderness. Just first is you look for the abnormal jaw movements. Evaluate with the steth. Look for any crepitus or clicking. That is one part of your clinical examination. Then palpitation, what you're supposed to see is you can look for any pain, tenderness in the temporomandibular region or preauricular region. You can ask a patient to open and close. You can really feel with your fingers. You see any, if suppose a total dislocations there in the TMJ, there will be severe pain when you palpate and see your temporomandibular joint. Then the associated structures is your temporal inflammation of the tendon, temporal tendonitis. Then the adjoining structures, that is the stylomandibular ligament inflammation. You have to look for those things. The other inflammatory disorders of your TMJ. See, we are discussing only about the prime clinical conditions that is useful for you students. Group of disorders in which the joint structure becomes inflamed as a result of any trauma. If suppose all traumas, for that matter, any traumas with the lower jaw, particularly your mandible. If suppose a fracture is there in the symphysis of your mandible or in the parasymphysis, you have to look for the opposite side of the temporomandibular joint. If suppose the fracture is there in the parasymphysis of the left side of mandible, then surely you have to evaluate the right TMJ condition. You have to see for any fracture is there in the temporomandibular joint, and those things can be clearly appreciated with the orthopantograph. Advisor X-ray, OPG. You can clearly not see the temporomandibular joint. And in the temporomandibular joint, fracture can be in the neck of the condyle. Most vulnerable site of fracture in the temporomandibular joint is your neck of your condyle. Most commonly, your neck will get, it can be either subscapsular or supracapsular, or within the capsule. Fracture can be within the capsule or outside the capsule. Don't bother about the management part, how it is treated. Only thing that is more concern for you people is you have to be in a position to diagnose it clearly. Looking for fracture where exactly is, either in the neck of a condyle, or if suppose the impact is so more due to any RTA, then eventually you can see fracture in the fossa itself or in the articular eminence itself. These three are the bony structures of your temporomandibular joint. And with the fracture of your bone, your adjoining muscle impact will also be there. That is one prime inflammatory condition. Then the next one is your disc derailment. Now, suppose there's something called as ankylosis of your TMJ, and that is the most commonly seen in the growing individual, the pediatric patients, where if any injury is there, any trauma to the mandible, any impact is there, direct hit is there into the mandible. Eventually, what will happen is, as I told you earlier, any impact, the bony part will get fractured. The muscle part or the tissues or the disc, that impact will be different. If it is left untreated, any assault to the mandible in a growing individual, if it is not evaluated properly, then slowly what will happen is your joint will get ankylosed. And that becomes a serious issue where the patient can't. Gradually, there will be in an ankylosing patient, it is not an acute condition. It is a chronic condition which is left untreated after any primary injury to the mandible. After any primary injury to the mandible, there can be a damage to the disc. That eventually results in the ankylosis of your joint. Then there will be gradual decrease in the mouth opening. As discussed earlier, when you evaluate the amount of mouth opening, clinically you check with 3 fingers. The problem that is more commonly associated with the ankylosis patient is there will be a gradual decrease in the mouth opening. And any acute of fracture, any direct fracture is there, then it will be a acute condition. That is one thing about the temporomandibular joint. Now, problem is there in the temporomandibular joint. There will be inadequate mouth opening. The other thing clinically you should notice is there will be a deviation in the form. That is nothing but there will be facial asymmetry. The path of closure of the mandible will be in a clear way. Either it can be deviated to the left or to the right. If suppose injury is there in the right side of your TMJ, then eventually what will happen is your mandible will get deviated to the left side. When your mandibles get deviated to the left side, it will end up with a facial asymmetry. That comes the next topic of discussion. Then you should bother about what is a facial symmetry. Then you should bother about your facial form. How your lower jaw, how your face is divided into 3 halves. The upper third, the middle third, and the lower third. The upper third is formed by the frontal bone of your skull. The middle is formed by the maxilla and the adjoining structures. The lower third is with your mandible. As discussed earlier, the deviation, if suppose the left or right side, wherever the problem is, then the patient eventually will have a facial asymmetry. That should be more readily diagnosed by a good clinician. Students, when a patient comes to you in OPD, when you examine, first thing is you check for you see the eyes, look for the changes that is there in the conjunctiva, or you ask the patient to open his mouth, ask the patient to protrude his tongue. You examine the intraorally, you see for the nasopharynx, you see whether any problem is there in the tonsils, and when you do all those things, you should eventually take care about your temporomandibular joint. This is the clinical sign, that is the deviation in the form. Then the other thing is the additions and the adherence. Then is your subluxation, and the most problematic condition is your complete dislocation of your joint. That is the worst sequence of the TMJ disorder. Total dislocation of your temporomandibular joint. And the other clinical sign is frequent dislocation. Every now and then, patient will get his mouth stuck, and that will be subsided readily after 1 or 2 minutes. So that will be there. That is a chronic condition that is called as spontaneous dislocation of your temporomandibular joint. That is the chronic condition. It will settle down by itself. Okay, that means it's the self-limiting, and even that can turn up to a acute condition where it can end up with a total dislocation of your temporomandibular joint. Now, before ending up this session, I need to highlight about the basic structure of your temporomandibular joint. I hope this session would have enlightened you the clinical importance of examination of your temporomandibular joint.